Welcome, everyone. I am Michele Nadeem-Baker, CLL patient and advocate. We are live with CLL Society's Ask Me Anything, a virtual event where we will spend the next 60 minutes answering your questions with a CLL expert. And we are so lucky to have Dr. Meghan Thompson from Memorial Sloan Kettering joining us today. There is no prepared presentation. This event is dedicated to you and your questions. Before we begin, I have an important disclaimer to share. Nothing said today should be taken as medical advice. Any questions about your own health and treatment should be discussed with your healthcare provider. Without any further ado, Dr. Thompson, would you please introduce yourself for our audience?
Hi, everyone. Thank you so much, Michelle, for the introduction and the CLL Society for this event. I'm really excited to be here with you all today. I'm Meghan Thompson from Memorial Sloan Kettering Cancer Center in New York, and I focus my clinical practice on CLL as well as clinical research and clinical trials in CLL. And really looking forward to hearing your questions and answering them and having a great conversation this afternoon.
Thank you. And now for our first question. And hold on, everyone. We have quite a few in already, and from those of you who sent them earlier for us to include. So for those of us approaching treatment, Dr. Thompson, for the first time, otherwise known as frontline treatment, can you please review the time-limited options for treatment of CLL?
Yeah, absolutely. And one of the things about CLL is that, as many on the call, the patients know, not everyone with CLL needs treatment. There's certain criteria, including symptoms, other laboratory parameters like your hemoglobin and platelet blood counts, and then things like enlarged lymph nodes or your spleen being enlarged. So there has to be a reason to treat the CLL. And relevant to this question is usually it is a gradual process. So one of the things I would recommend is, having these discussions over the course. Often they can be had over multiple visits. So I think it's really good that we talk about this now. The treatments as of November 2025, I'll kind of go through. So there's kind of two major pathways. There's a continuous pathway, and that traditionally has been the drugs, the BTK inhibitors. But focusing on fixed duration, the approved by the FDA fixed duration regimen in the United States is venetoclax, which is a pill-based targeted therapy in combination with an IV infusion that's kind of like an early immunotherapy infusion called obinutuzumab. And as this regimen is given in a standard fashion, it's about 1 year of what we call fixed duration or time limited treatment. You get 6 cycles, which is about once a month of the obinutuzumab. There's a couple other doses up front. And then the venetoclax is for 1 year. So that's the main time limited treatment we've had. But
Now,
over the,
is
yeah.
that the one that will have the most promise for a deeper and more durable remission?
Yeah, great point, Michelle. So, at the end of this treatment, many patients actually are in a deep remission. And many patients actually, when we do a really sensitive blood test called minimal residual disease testing, we actually can't detect the CLL cells in the blood, even with a very sensitive test. We don't, at this point, think that it's a curative treatment option, meaning that the CLL does tend to come back over time, although there's patients that have years and years of remission. It's about a 6 year average from starting the treatment to the CLL progressing again. But at the end of this treatment, many patients are in a deep remission and then can have several years off of treatment.
That's
We
one.
do have, yeah, one of the things I wanted to mention though that you might begin hearing about is there are some other emerging options. And so, um, Over the past year, a clinical trial last, our kind of annual big American Society of Hematology meeting is upcoming in December and happens every December. And a lot of new studies are presented. And there was a study that was presented that actually looked at combining a BTK inhibitor pill with a venetoclax pill for a pill-pill combination. And this is a acalabrutinib and venetoclax. This is not approved by the FDA currently. It is, however, listed in our National Comprehensive Cancer Network guidelines or NCCN guidelines. And so it is a treatment option that your physician may discuss for you. And it is a time limited or fixed duration treatment option. It's a little bit over a year of treatment. And then there's actually along that same vein, not approved by the FDA currently, but based off that same clinical trial listed in our National Comprehensive Cancer Network guidelines is the acalabrutinib, so BTK inhibitor, venetoclax, and obinutuzumab. Now, there's different risks and benefits with these treatment options based on certain CLL characteristics, other medical issues. Your doctor will kind of talk to you through the pros and cons, but I just wanted to bring up those newer options that I think you'll be hearing more about in the future.
Can you please contrast those with the use of continuous therapy, which would be the BTKI inhibitors? And also, maybe could you explain what BTKI means?
Yeah, absolutely. Let's start with what BTK is, because this comes up a lot. And there's um, BTK inhibitors are standard treatments. There's clinical trials of drugs called BTK degraders. So you keep hearing this BTK word. And what BTK is it's a key pathway in the CLL cells that through signaling or communication this pathway helps the CLL cells grow and survive. And so BTK inhibitors actually block this pathway, and by doing so, are able to prevent the growth of CLL cells. So they're a type of what we call targeted therapy, where they're pill-based treatments that actually target a really important process that the CLL cells use to live and survive. And these drugs actually kind of turn that off. Um, as you mentioned, Michelle, these are given continuously as they're approved currently by the FDA. These days we're often using drugs like acalabrutinib or zanubrutinib that are very, very effective pills. Um, for example, um, at 6 years of treatment on a acalabrutinib pill, about 70% of patients, the CLL is still in a remission and doing well. So people can be in a remission with these medicines for years and years. However, they work in a very different way than that pill infusion combination or even the pill-pill combinations. And so the intent of the treatment is to continue it either until it stops working, or, of course, if a patient had a side effect that was bothersome, that would also be a reason to discontinue the medicine. They're two different approaches. It's really patient specific. There's pros and cons to each. BTK inhibitors are very convenient. In general, they're very well tolerated and easy to administer. And certain features of the CLL might point your doctor towards a BTK inhibitor. Having said that, they are a continuous medicine, and so the side effect can be cumulative over time. And also, from a patient perspective, being on treatment, for a prolonged period of time is also something to take into consideration.
As someone who's been on, this is my second time on BTK inhibitor because it worked so well the first time. I just went over the 4 year mark, and it'd be nice to have a break in treatment someday. And I'm also hoping things don't start to, I hope they continue to work for all of you out there. I know that they have worked for others for quite a long time. So you mentioned a triplet. So we have another question. Can you review the use triplet targeted therapies together? And you had talked a little bit about this and whether they are showing promise for deeper and more durable remissions. I mean, why add on additional drugs? Have you prescribed these as a frontline treatment?
Yeah, that's a great question, Michelle. And this is a really evolving area. As you mentioned, many patients do well with just with one drug alone, can be very, very effective. And so the thought of adding, multiple drugs or three drugs, I think there's a couple of thoughts behind it. So one is for patients who prefer that time-limited approach to try to get patients into a very deep remission so that time off treatment can be potentially longer. The other is their CLL is very different for different patients, and some patients have different kind of genetic makeup of their CLL that perhaps using a more intensive approach makes sense. I will say, the triplet, just to explain kind of that terminology again, is BTK inhibitor, a drug like venetoclax, which is called a BCL2 inhibitor. It's kind of its class of targeted therapy. And then this IV infusion obinutuzumab, which is again an antibody treatment. I think of it like an early immunotherapy type treatment, and it targets a protein on the surface of the CLL cells. And these have been combined and shown promise in clinical trials. It's actually not currently FDA approved. We do list them in the National Comprehensive Cancer Network guidelines, so it is an option that might be available to you. But one of the things we do see very promising results with the triplet. I think it certainly it appears that kind of we have less follow-up or less time that we've been using the triplet, but it certainly appears that many patients are able to get into that deep remission. There can be a trade-off in terms of infection risk with it is one of the major things. So more drugs, the more potential for side effects. And so it really depends on your specific treatment goals, as well as kind of your doctor's assessment of your other medical issues and the risk for infection, and kind of weighing those pros and cons in the discussion with your doctor. I've been part of clinical trials. So at Memorial Sloan Kettering, we've had a clinical trial with the triplet, and so I do have experience using it, and I think it works, well for patients. But CLL is not a one size fits all approach, so I think in facing that decision, it's good to think through, well, what would the potential side effects and potential kind of pathway of treatment and time on treatment look like with a triplet versus BTK inhibitor versus a venetoclax-based treatment?
So you were talking about when making the decisions for which therapy is best for a patient. So what are the key considerations from a medical point of view? You mentioned medical history, but what types of things would you be looking for?
Yeah, I think always thinking about cardiovascular or heart side effects is important because um, for any regimen, you kind of want to know what the baseline heart function is, but the BTK inhibitors in particular do over time have a risk of increased blood pressure. And so, for example, if it's been difficult to control blood pressure, maybe veering towards another option, if there's another option like venetoclax might be advisable. Or there's about a 5 to 15% chance with the BTK inhibitors of a heart arrhythmia called atrial fibrillation. So still, happens in few patients on a BTK inhibitor. But if there's a history of a cardiac arrhythmia, it doesn't mean you can't use a BTK inhibitor, but I just do engage with the patient's cardiologist, primary care physician to think about those things. Venetoclax has its own set of risks, and so there's a risk of something called tumor lysis syndrome with venetoclax, which I think about that, like basically the venetoclax is so effective at first that it bursts open the CLL cells, it can release potassium, it can affect the kidneys. We have many methods actually to prevent this, so that's a very rare thing to happen. but you're higher risk if your lymph nodes are bigger or if your kidney function is a little decreased. So really weighing those parts of the medical history. And then thinking about the CLL, there's different mutations or genetic features of the CLL. It's not that one mutation means you get one treatment. We're definitely not at that point in CLL, but all these kind of factors come into play, or you have really big lymph node. Some people might have that, and this tumor lysis syndrome risk might be a little better. You might have to go to the hospital for a dose. All these factors kind of come into play, and then the logistical considerations. There's different monitoring required on treatment, and we really want to make sure the CLL treatment is feasible for patients' lives and quality of life and things like that.
Can I just reflect on something you just said? So we are at a point that's just so different than when many of us were first diagnosed with CLL, and that's that we do have these choices. And to ask our doctors if they can guide us in which treatment may be best for us, it wasn't like that not all that long ago. Where there was one gold standard and it was chemotherapy too, combined with something else. So we really are in a great time and it's getting better, hopefully, with CLL. Um, which brings me to a question someone asked, and that is there any speculation you have on how long before there's a cure?
Oh, wow, it's such a good question. I think, the CLL, as you mentioned, Michelle, has just really drastically changed for the better, really year by year. I think we're going to be if we do this program a year from now, we'll be talking even different, even potentially in the frontline setting. So there's been two FDA approvals for CLL over the past 2 years of drugs, and there's many more drugs in development. When we talk about cure, that is the goal of CLL research, right? Um, but I think one of the tough parts, and I think we're going to hit on this in some of the other questions that were submitted by patients, is that for CLL, there's treating the cancer. And then we know that with CLL, there's also the increased risk of infection and a slightly increased risk of other cancers, such as skin cancers and other malignancies. So when we think about cure, it's both getting rid of the cancer, but also functionally making sure the infection risk isn't increased and things like that. And so those are the two main things. I think we're doing a great job at getting rid of the CLL. But one of the research focuses, I think, is also making sure that with our treatment, we're not increasing the risk of infection or future side effects too. So I can't put a timeline on it, but I'm really, really hopeful with some of the combinations of these targeted pill-based therapies with some of the newer immune-based therapies that we have in development. And I do want to, bring up that patients with CLL, there's been studies done now that when we use the treatments we have available in 2025, looking at CLL patients and patients without CLL in a general population study, the lifespan does not appear to be significantly different. So we aren't at the point of cure right now, but we are at the point of managing the disease. But a lot of research going on that hopefully we do get to that point where there's one treatment and we're rid of the CLL.
Well, I look forward to the cure as you defined it. A lot of us experience infections pretty frequently, and that would be, I mean, all of what you said is music to many of our ears here. Since patients with SLL have much less CLL in the blood, and it would be more lymph node burden. Does blood-based MRD testing for SLL patients actually reflect the load? And have
Well,
studies
yeah.
compared SLL MRD with CLL results with the same markers? Great question.
What a great question. I have the same question. So I think this is like hitting on some of the research that's going on now. So For patients with SLL, as long as they do have some detectable cells in the blood, which in almost all cases they do, we can use this MRD or minimal residual disease testing. But the point is a really good one that sometimes patients, even when we can't detect CLL in the blood, they finish the treatment, they're in a remission, they're feeling great, and maybe the lymph node's still a little enlarged. And this question comes up, is it just a scarred lymph node, or is there still some cells there? Is this test really good? I think on the whole, the test is pretty good because we know that there's patients from studies who've had, maybe a little enlarged lymph node still when they stop the treatment and they're undetectable in the blood. And in general, that they still have a very long remission. There are some newer tests, though, that aren't available outside of a clinical trial, but researchers are working on to look at tests called circulating tumor DNA that actually it's a blood test still, but it actually looks for cells shed from the SLL in the lymph nodes, or even if you have CLL, the CLL in the lymph nodes. And that might be a better measure of the lymph node disease and is a blood test that is being monitored. It's not clear yet from the research that's been done that that's better, though, than the blood MRD testing, but I would say stay tuned. And what a thoughtful question that I think we'll learn more about in the coming years.
Uh, we have a series of questions that follow on to the BTKI discussion. And here's one of them. This patient says, I have CLL and have been on acalabrutinib for nearly 6 years. My hematologist says guidelines don't suggest taking patients off of it, so that would be continuous treatment. Yet a recent webinar, physician claimed her patients continue to do well after they stop taking it. Can you explain what the practices are?
Yeah, this is a really, I think, question that applies to so many patients and is also an area we're learning more and more about. Um, I'd say, again, CLL is very heterogeneous or different in different patients. So it really depends on your circumstance. There are, as it's approved in studies, it's a continuous treatment. And there are some patients that will, for example, your CLL might just be very sensitive to the BTK inhibitor if you're a patient with CLL. And if you maybe stop your BTK inhibitor because you're having a procedure that has an increased risk of bleeding, sometimes patients will actually get symptoms stopping their BTK inhibitor. And it doesn't mean their CLL is out of control, but it just doesn't agree with them to be off the medicine. But we actually know from clinical trial, there are some patients that actually do fine when they stop the BTK inhibitor. So we never really plan to stop it in general, but sometimes things come up. So what's an example of that? So say you're on the medicine and you have a new side effect on the medicine and the CLL is under good control. Oftentimes this means you've been on the BTK inhibitor for a couple of years, the CLL is under control, a side effect comes up, and patients stop the medicine. Or something happens where, unfortunately, in some cases, access to the medicine has been an issue. And there's a lot of programs to work on that, but it has happened, and I've seen that unfortunately happen. And there's two clinical trials actually that shed some light on like what one can expect. So one is there was a clinical trial of actually ibrutinib, which is an earlier the first BTK inhibitor. And patients who stopped for reasons other than the BTK inhibitor stopping working. So the CLL was under control, but they stopped. They hadn't planned to stop, but something happened and they stopped it. There was actually about 2.5 years before the CLL progressed on average. Now, there was a wide range to that. Some people weren't able to be off the BTK inhibitor. Some people it was longer than 2 years before they needed treatment again. So there are cases with patients where they've stopped for another reason. whether it be a side effect, they had an infection, there's something else going on medically, where I do reassess the CLL at that time point, and sometimes we discuss it and do decide to not resume the BTK inhibitor and are do careful monitoring. And then at our center at Memorial Sloan Kettering, we have a clinical trial where we gave the BTK inhibitor acalabrutinib. Patients did get obinutuzumab for 6 months with the acalabrutinib. So it wasn't just a BTK inhibitor alone. And patients were able to stop early if they were undetectable, minimal residual disease, if we couldn't detect the CLL cells after 1 year. But then actually everyone on the study stopped the BTK inhibitor after 2 years. And so we're still learning what the experience is from this trial, but I can share that it was an average of about 2 years. Again, that seems to be the mark where patients were able to have what we call a time off treatment. So I do think we're going to see more and more data from patients where maybe a break is feasible. It might not be for everybody, but I think it's something to talk to your doctor about.
Someone else asked this other question. So if a patient goes on a time-limited treatment with a BTKI combination, which would be what you were just talking about, uh, can they use a BTK inhibitor alone if and when they relapse as a second line of treatment?
Yeah, these are such great questions. It's like perfect segue into what we were just talking about. I think in most cases, yes. I think you always, how I always approach it with the patient is, why did we stop the treatment in the first place? So if it was like a really bad side effect that we think you're going to experience again, or to be honest, is going to impact your quality of life again, and we don't want to go back there and we have another option, then maybe we don't do a BTK inhibitor again. But if it was like some other reason, like it was a minor side effect, or there was an infection, or some sort of procedure, or other medical issue that came up that led us to do that in the first place, or it was a minor side effect, you know, there is some limited, albeit limited data, but there's no reason to think that you couldn't use the BTK inhibitor alone again. And for patients who got BTK inhibitor and venetoclax, there's some studies that are coming out now showing that exactly what you've brought up does work and people respond. So definitely an option.
Is there a process for coming off of acalabrutinib with monitoring? And are there pros and cons to being monitored or not being monitored, or a process, so to speak?
Yeah, I mean, again, outside of a clinical trial, it's not really standard. It's not in the guidelines. So there's no protocol, I would say. But for the patients where, say, they've had a side effect and we stop the acalabrutinib, for example, I do kind of closer monitoring in terms of, making sure there's no growing lymph nodes on the physical examination, maybe a little bit more frequent blood work than we were doing on the treatment, depending on the patient situation to monitor. But I'd say it's still an area that's mostly being developed in clinical trials, so there's not a standard, and it would need to be personalized to you with your doctor.
How critical is a karyotype? And maybe you can explain that in your answer. And do the recommended treatments differ from those who are at the highest CLL risk? And is there a difference in overall survival for those with a karyotype?
Yeah, so a karyotype, just to explain, is when actually all of, and this is referring to the genetics of the CLL cells specifically, so like not the genes that, so we all have karyotypes or genetics that we were born with. But this is looking at the cancer cells, and what can be done is looking at all the chromosomes which contain um, the genetics of your cancer cells is how you can think about it. And there's certain abnormalities in the chromosomes that we know are common with CLL. And those are done often by a testing called FISH testing. So some of you might have heard of deletion 13q or deletion 17p. So that's kind of specific focused chromosomal testing. A karyotype is actually when a process is done and CLL is very slow growing, that in the laboratory they actually stimulate the CLL cells. They have to get them to grow faster. And then they look at the cells in different phases. And then they look at all the chromosomes and look for changes from what we call a normal karyotype, or there's a way that the chromosomes normally look. So it in CLL, doing this, and every institution does it differently. So at Memorial Sloan Kettering, we actually don't do what's called a karyotype on the peripheral blood. We do something called SNP array analysis, but we do a karyotype on the bone marrow. So there's a lot of like technicalities involved, but in general, if you have a karyotype done, if there's 5 or more abnormalities in the chromosomes of your CLL cells, that's considered to be higher risk. It used to be defined as 3 or more, but it seems like actually 5 is probably a more accurate number. You know, it's a risk, but it doesn't mean that treatments won't be effective. And so it's just one piece to the puzzle. It is testing that you should ask your doctor about doing before starting treatment because it won't necessarily change the treatment, at least not in 2025 that you receive, but it could help your doctor give you a sense of what the likely time on that treatment is, or time before the next treatment is, or length of remission, and things like that.
Here's a general question. Is it better to do time-limited therapy or to take treatment ongoing until no longer tolerated or relapsed?
Yeah, what a great question. I don't know the answer to that because there really hasn't been, there's been a couple of clinical trials, but there's been no definitive clinical trial using the drugs we use, today in 2025, even in 2024, that have looked at like continuous versus time limited. There is a study that's going to be presented in just a couple weeks at that big United States American Society of Hematology meeting that is going to look at patients who are treated with continuous ibrutinib versus time-limited venetoclax obinutuzumab and then ibrutinib venetoclax. So the results of that study, I think, will be informative. However, it's really hard because we're not, ibrutinib tends to have more side effects than acalabrutinib, zanubrutinib, and so it's not exactly maybe the regimens we're talking about, but that study could help kind of answer this question in some ways. And then the genetic features are also, potentially at play here. So there's some thought that maybe patients with P53 mutations, maybe a continuous regimen is better, but this is based off of a very small number of patients. And again, there's no definitive clinical trial. So it really needs to be personalized to the patient's case and all these factors. But that's one of the reasons it's a good problem to have in a way in CLL that we have so many options. But it is, I understand, it does make for this treatment decision to have, I really view it as an opportunity to really review in detail, often over the course of several visits, what the treatment options are and what would be the best fit for, you as a patient, and also your CLL characteristics.
Next question has to do with AIHA, which would be great in your answer if you can explain what that is for our audience. So a recent study showed benefit from stopping BTKIs in terms of quality of life. If a CLL patient is tied to AIHA, hemolytic anemia, would the patient expect to see the same benefit, or does the link to AIHA make a difference? In both scenarios, what's the best strategy for monitoring the progression-free status? Wow, what a loaded question there.
Yeah, that's a complicated question for sure. So
Bill,
yeah,
this is your, by the way, this is your turn
let's
to run
talk
for a
about Michelle.
match.
I think your point. So um, AIHA is, as Michelle mentioned, is hemolytic anemia. What the AI is autoimmune hemolytic anemia. So um, this is something that can happen in patients without CLL where but it's more common. It's quite common, and it doesn't happen to all CLL patients, but it's not an uncommon occurrence in patients with CLL where your immune system actually makes antibodies and you're destroying your red blood cells, and so the hemoglobin goes low, and you can be anemic. And this is thought in CLL patients to be driven by the underlying CLL. And so it's, if you've heard of autoimmune diseases, CLL is a cancer of the immune system. And then there's other autoimmune diseases. Autoimmune hemolytic anemia is a process that is really like an autoimmune disease where your body is producing antibodies that are destroying red blood cells. And when you're anemic, you can become tired, the hemoglobin can go low. And so there's a couple of different actually treatment approaches to this. Some patients with autoimmune hemolytic anemia and CLL can initially get treatments like steroids. Sometimes they'll get treatments like infusions like rituximab, and sometimes they don't need a BTK inhibitor. Other patients, the process of these antibodies destroying the red blood cells might be more difficult to occur, or patients might have gotten steroids before and it comes back again. And it's very manageable in most cases, this autoimmune hemolytic anemia, but it is disruptive to be wondering, is it going to come back again? And so BTK inhibitors are often a treatment that are used, especially after steroids and rituximab for autoimmune hemolytic anemia. I don't know of any data specifically on looking at patients with CLL being treated with BTK inhibitors with the history of the autoimmune hemolytic anemia and what happens when they stop the BTK inhibitor. I would think that just based on kind of my clinical experience, that there is a higher risk of the autoimmune hemolytic anemia recurring if you do stop the BTK inhibitor. But I will say it's not something we see the autoimmune hemolytic anemia, but I haven't had many patients stop or seen research on that. So that's maybe an understudied area that we need to learn more about.
If I experienced arterial fibrillation from acalabrutinib or another BTK inhibitor, it sent this patient to the hospital and now it's controlled. Is it safe to continue with, let's say, acalabrutinib or zanubrutinib as it appears to be working for the CLL?
Yeah, this is a great question. It does come up all the time. So in general, yes, if the atrial fibrillation is well controlled, I always kind of check with the cardiologist about the status of the atrial fibrillation, make sure there's a plan for medical management of it. Sometimes there was another provoking, certainly the BTK inhibitors increase this risk. But there can be other factors like an infection, like a pneumonia can increase, can be kind of an acute trigger for the atrial fibrillation as well. So making sure those other things are optimized and under controlled. And then heart arrhythmias can be incredibly complicated. And so just making sure that there's no other risk factors the cardiologist is noting kind of on their evaluation before restarting. There are some cases where when those other risk factors are present, that might be a time to consider, especially if the CLL is under good control, this reevaluation and whether maybe a break could be warranted. In cases where the CLL, you know, would benefit from further treatment in the immediate moment. I think there are some cases where you might switch to something like venetoclax just to not have to worry. Once you have atrial fibrillation, there's a risk of future atrial fibrillation, BTK inhibitor or not. And so following with the cardiologist either way is important. You could go the venetoclax route if that's an option. Or there are patients who can safely go on the back on the BTK inhibitor. The oncologist, cardiologist work together. So a lot of different potential options there. Something that comes up a bit.
Wow, we haven't even gotten through half of our questions, and we have 81 more questions that have come in live. I wish we could spend more than, I believe we have an hour only. I wish I could go and fast forward here, but let's try. Wow. Um, this patient has had pain in their spleen area for 10 months and it's worsening, but the doctor says their spleen is not enlarged because he can feel it. What may be going on?
So there's pain. Let me make sure I understand. There's pain in the spleen area, in the spleen area. So your spleen's on your left side, but the spleen on the physical examination has not thought to be enlarged.
Correct.
Okay. Yeah, that's an interesting case. I would say those are sometimes cases where we don't always do, and I know patients had questions about imaging, scans, so maybe we can address that a little bit with this question too. So we don't always do imaging like on, there's some cancers where maybe you get a CAT scan every 6 months. Routinely when not on treatment or after treatment. And so in CLL, it's often driven by symptoms. And so this might be a case where I would start with an ultrasound and then consider, depending on the symptoms, exam, if it's really persistent pain, things like a CAT scan might be an appropriate next step. There's other organs in that area too. So sometimes it could be a gastrointestinal issue. And so seeing a gastroenterologist, sometimes they do like a scope, like an upper endoscopy, which is similar to a colonoscopy, but looking in your esophagus and stomach to see it could be a reason unrelated to the CLL. Very rarely patients can get something like a splenic infarction, but usually that's when the spleen is enlarged. So, would be good to talk to your doctor about, other potential gastroenterology or maybe doing an ultrasound or even CAT scan.
What is the significance in treatment and prognosis of elevated monoclonal IgG, kappa, and free light chains that continue to climb without significant elevation of ALC? Are these coming from antibody secreting cells? And if so, what are they? Uh, so there's a lot to unpack in here.
Yeah, that's a really advanced, like sophisticated question.
Extremely.
So I think, this is how I would think about it. I mean, I can't answer it without seeing the
Mhm.
laboratory work because basically, what is IgG? Let's talk about that. So IgG is a blood test that many of you may get with your doctor at some point or another. And it measures, it's called immunoglobulin G, and it's a marker of antibody production. And your B cells are the cells in your body that produce antibodies. And in patients with CLL, they often actually have low IgG. And so some of you might have heard of something called IVIG or intravenous immunoglobulin, which is sometimes um, given to patients to prevent infections if they've had serious infections and have low levels. This question is asking about high IgG. And there are some cases where the CLL can produce extra IgG and to figure out if this is related to the CLL or this is another process. It's a little bit of a pathology question, and it looks at surface markers on the CLL by a test called flow cytometry. And then you can do special tests called immunofixation and protein electrophoresis on this IgG protein. So it's very complicated and patient specific. And then sometimes you can have polyclonal IgG. What does that mean? With an autoimmune disease, you could get IgG. So there's many reasons behind that, but I would say for that patient, I would ask your doctor about whether the protein's been tested. Um, in and of itself, IgG typically um, is not such a problem to be elevated, but in some patients it is a marker of the activity of the CLL. And you can also have high IgM. Some of you might have heard of that. That's another type of antibody. But there's other things that can cause that as well.
We just have, I mean, people here are really smart about their CLL. We have a very educated audience here, the CLL Society. Uh, I don't even know where to go here. We have so many with not much time left. Let's switch quickly to preventing infections and lifestyle. And it's that time of year for the flu and, more prominent numbers of COVID and RSV. So, trying to summarize a lot of what these questions say. What vaccines do you recommend that we all get? And are there any effects that can have on us and our CLL? Can any of them increase our CLL numbers? Can they make it flare? Are there any we stay away from during treatment? I think I've now covered all of it here.
Yeah, these are great questions. So, with CLL being a cancer of the immune system, patients with CLL are at higher risk for infection than patients without CLL. We don't have a great blood test in 2025 to say, how immunocompromised or how much increased infection risk a patient with CLL is. And it exists just as CLL does on a little bit of spectrum. So there's some patients with very frequent infections, and then there's some patients who are less frequently have infection. For all patients, generally should not receive any live vaccinations. Now, there's not many live vaccinations that you would get as an adult, but I always tell patients to reach out, to the office if you're traveling somewhere, for example, and the travel doctor recommends vaccines. I do recommend flu vaccine. I recommend the Shingrix vaccine, which is a two-part vaccine series, a pneumonia vaccine. There's a new one out called Prevnar 21. What the timing of that, there's older pneumonia vaccines. Many of you might have gotten Pneumovax or Prevnar 13 or even Prevnar 20. So that's something to talk to your doctor about based on what you've kind of had already. There is an RSV vaccination that is not a live vaccine, and then COVID vaccination. And, to the question, I guess, about flaring of the CLL, there's nothing that we know of with these vaccines that makes the CLL progress faster. Are there patients who have a rise in their CLL after getting a vaccination? Yes, but it's very difficult to pinpoint whether that would have happened anyways. One thing that does happen when you get a vaccine, even patients without CLL can get this, are the increase of the little swelling of the lymph nodes right after the vaccine. But that's the immune system's response to the vaccine. So that's not unexpected. And so that's something that can come up, but it doesn't necessarily mean the CLL is progressing. And then in terms of treatment timing, this is very specific to what treatment you're getting. There are, certain cases where treatments will make you less likely to respond to the vaccines, and so the timing might be delayed. The best thing, if you're able, is to actually get the vaccines before recommend vaccines before you start treatment. So if you're in active observation or active surveillance of CLL, that's something to kind of check through to see if you're up to date on those vaccinations.
That was great. Thank you. Very comprehensive on that. Uh, Bug bites. I see this all the time. I have it happen to me. It's all the time on our various support groups online. So it seems to be a thing. Is it a thing with CLL patients, or is it all just coincidental for all of us?
No, I think it's definitely something we've observed that for patients who maybe haven't experienced this, because not every patient does, but it does come up, that especially in the summer with insects like mosquitoes, many patients will get a mosquito bite and have like what we call an exaggerated reaction to it. So there can be a lot, actually a significant amount of swelling, redness, warmth in the area where the bug bite is. And so this is often able to be managed um, with topical steroid type treatments. There are some patients who have more severe cases of this, or there's patients who maybe have a skin rash and they have the swelling or these spots crop up, but they don't remember like being outside or in an insect area and they're not sure if it's an insect bite. In those cases, I have patients see a dermatologist. There are very rare skin conditions too that are associated with CLL. And can be managed with different topical treatments as well as injection treatments. Um, there's something called eosinophilic dermatosis of hematologic malignancy that we see in CLL patients. So definitely if this is coming up, I would bring it up with your CLL doctor. And it might be advisable to work with a dermatologist too and see if there's any additional strategies to manage this.
Uh, we have one on sinus staph infections. Is it typical for CLL patients to have them? And is it typical for them to be unresponsive to numerous antibiotics?
Yeah. I think, certainly there are infections, especially sinus infections, pneumonia or respiratory infections, and even skin infections we see at higher incidence, and staph is a common bacteria. Um, Many patients are responsive to antibiotic therapy. It depends a little bit on the specific bacteria. Um, where the infection came from. There are these cases in patients with and without CLL of resistant bacteria where sometimes other strategies in terms of alternative antibiotics that maybe aren't as more commonly used need to be employed. So I don't know that necessarily staph is more common or resistant staph is more common, but it is something that may come up.
Um, the next one is on exercising and higher white blood counts. So does doing a workout, this particular person they run 6 kilometers, that's a little over 3.7 miles. Does it cause your white blood count to rise, or is it any exercise? All exercises are just cardio. And how long should someone wait after this type of exercise to have a blood test done?
Oh, what a great question. I'll admit I don't know the exact answer to it. I think your white blood cell count can be affected by so many things. In general, in patients with CLL, many of the cells are CLL cells, but inflammation, infection, all these things can affect it. So if the workout is causing some inflammation, it might increase the white blood cell count a little bit. That's why I never put too much stock in any one blood value. I think it's all about trend over time. And if there's something really abnormal or unexpected, repeating that, not necessarily immediately, but at some point in the near future, is advisable. And I tell patients, and we see this, like they get their blood checked maybe with another doctor, and then a week later, like the blood count's a little different. And some of that might be that labs are a little different, but it's kind of like we check your blood count on Monday, it's going to be one thing. On Friday, it's going to be a little bit different. So it's all about kind of over time with CLL. So I don't think you necessarily need to wait, after your workout to check the blood count.
Uh, some of us are told when we are in remission, what does that mean to our compromised immunity? Can we integrate more into society, out to dinner, visit with friends and family with more confidence? And will it still take longer to recover from a possible illness? Or do we still have to keep our guard up, or can we go back to everyday activities?
Yeah, this is a really important question. I'd say we don't know fully the answer to this question, and it does depend a little bit on what treatment and how long after the treatment it's been. There's, maybe some data that while the treatment decreases the immune system, maybe some emerging data at the early phases, it's just understudied right now, that treatment might lead to some immune restoration. And so, um, while patients with CLL are always at higher risk for infection, my advice is kind of to follow some common sense guidelines in terms of it's not always feasible, but try to avoid people are sick, hand washing, things like that. And then it's really individualized to the patient. Certainly, quality of life, being able to visit with friends and family and do activities that are important to you. And this is really my perspective as a CLL doctor, not necessarily, and it's really individualized to the patient, but I do think it's important to be able to do those things that are important to you. And then, just keeping in mind if someone's sick, avoid them. But hopefully we'll hear more on this. And I think this is a great point to close on in the coming years. I think there's a lot of research being done because this, as you mentioned, impacts quality of life and really health as well, about infection prevention and how we can restore the immune system. So I would say stay tuned on this topic, and I'm hopeful that we'll make a lot of progress in kind of understanding the risk and being able to provide more definitive answers in the future.
Dr. Thompson, this has been great. We need 2 more hours for all of these questions that are still coming in. I hope you can come back and join us again.
Yeah, I would love to. This has been really, the hour just really flew by. It's really fantastic. I loved hearing what everyone was thinking about and would love to continue the conversation in the future.
I'm hoping to see you at ASH, but before we close the program, do you have any closing thoughts for our audience?
Yeah, I just want to thank the audience for such great questions. It's really, I'm always amazed and impressed by the questions asked by our CLL patients. And this is really, I just want to tell patients that there's a lot of, right now in 2025, we have great treatments for the CLL, but there's a lot of exciting new treatments coming out, or just refining the way we're giving the existing treatments, which many of you were asking about in your questions. Like, okay, we know about BTK inhibitors and venetoclax, but like, how can we modify how we're giving it? And that's what we're doing in research, in collaboration with patients, their families, and then doctors and laboratory scientists. We're all coming together to refine this. So I'm really excited and hopeful for the future, and would love to do another one of these events. It was great.
It's been great having you. Thank you so much for your time and your expertise. You weren't throwing any curveballs here. We are very grateful for your participation. I just want to thank everyone who joined us today. And we'd also like to thank our generous donors to the CLL Society and grant support from Genentech for making this event possible. Don't go away yet. Please complete our brief event survey. We really want to hear from you and your feedback. And our next webinar for CLL Society is on January 14th, and that will be everything on ASH 2025, and it's coming to you. And you'll be able to learn the breaking CLL research as presented at the American Society of Hematology annual conference, which is in just a couple of weeks, folks. So if your question was not answered today, please send it to our Ask the Expert email service. This is a free service and can be found on the CLL Society website under Programs and Support. And please remember that CLL Society is invested in your long life. And you can invest in the long life of CLL Society by supporting our work. For CLL Society, this is Michele Nadeem-Baker. Thank you so much for being here with us.